Hello everybody, this is Dr. Dilshod. Today our guest is going to be Dr. Dagar from Max Super Specialty Hospital, Saket, New Delhi. And today's topic is going to be about congenital heart defects in children and how it happens and etiology, how we detect it in the early stages and what kind of diagnostic steps we have to take. And today Dr. Dagar is going to share his experience with us. I have had the privilege to know him over the last 10 years and I have personally witnessed him to take on the most complex congenital heart defects and successfully complete them. And it's an honor to see you today, Dr. Dagar.
Dilshod, it's a pleasure. Knowing you and the other members of the team for the last 10 years has been a pleasure.
Thank you.
And it is also very, very gratifying for me to look back over the last 10 to 12 years and reminiscent on all the children that we've been able to help. And it gives me a lot of satisfaction.
Yeah.
Over the years, I've also realized that parents who are traveling overseas generally have a lot of questions which they have not had addressed in their parent country. So through the medium of this podcast, I would like to take the opportunity to address some of the common questions, take away some of the myths, and generally establish a platform which is going to be helpful for the parents before they travel to overseas countries for the treatment of the children. Most important thing is that we don't understand is the magnitude of the problem. The first thing that parents generally come and ask me is why me? Why is my child with a congenital heart defect, right?
It's painful.
It's very, very painful, right? So I would just like to say here that it is more a matter of chance. Science has really looked at it as to why congenital heart defects happen. But unfortunately, even till date, we are not able to put a finger on any one particular sequence or a issue which can lead to a congenital heart defects. What we do know and understand is that there are certain groups or constellations where it is more likely that you can have a congenital heart defects. So it is things like certain social issues like the mother smoking or taking alcohol during pregnancy, especially the earlier weeks and months. Certain medications like certain anti-epileptic medicines, certain medicines which are used for convulsions, things like lithium. They are sort of more prone to a child having a congenital heart defects. What is also known is that the older the age of the mother at pregnancy tends to sort of lead to a higher predisposition. It's not a cause and effect, but the percentage or the chances of having a congenital heart defect.
The factors that play a role in it.
Yes. Consanguinity is another one. And if you already have a congenital heart defect in the family, be it either the sibling or the other children, then the chances of having a congenital heart defect are slightly higher compared to the other normal children. The good thing is that even if you have one pregnancy where you have a congenital heart defects, the overwhelming majority of the time, the subsequent child is still going to be a normal child. So that should give a lot of hope to parents. So like the percentage of any pregnancy having a congenital heart defect is around 1%. In subsequent pregnancies, it becomes about 2 to 3%. So there's still a 97% chance that you are going to have a healthy, happy child.
But still, it's slightly elevated than
it's more elevated than the other subsets where you do not have these issues at hand. Just to put it into perspective, people generally don't seem to understand that congenital heart defects are a huge problem. They are the commonest cause of death in the first few weeks to months of life.
Yes.
And the magnitude is such that if there are 1,000 live births, 8 to 10 children will be born with congenital heart defects. And what happens is that this thing keeps accumulating. So in a large country like India, it just sort of multiplies by leaps and bounds.
Yeah.
So at any given time, we have about 300,000 to 500,000 children who need congenital heart defect repairs at any given time.
The higher the birth rate, the higher the likelihood of having the congenital heart defects, right?
So it is just an expression of the fraction that we discussed. So worldwide, it's around 8 to 10 children with congenital heart defects for every 1,000 live births. So the more pregnancies and the more births you have, the greater is going to be your load of congenital heart defects.
Do you know any ethnic groups that you would see higher likelihood of having these heart defects, or there is no ethnicity relationship?
So not really, but yes, there's certain defects which would tend to cluster within certain ethnic groups, but generally they are sort of pretty equally spread across. Yeah.
Okay. As far as prevention concerned, is there any studies or scientific information, like any gene involvement or any genetical like let's say in a Down syndrome, there is a relationship between Down syndrome and ASDs, right? The common, like, is there any genetical defect that you would see in a child that you would see the congenital heart defect that related to that gene?
So, Dilshod, that's very true. There are certain genetic effects which would have a clustering of congenital heart diseases. The commonest that we encounter is Downs, and it is very common to have AV canals associated with Downs. They're also more predisposed towards having VSDs. There are certain other defects like the Turners. Then you have the other clusterings which can happen. The supravalvular aortic stenosis is more common with the Williams syndrome. So yes, clusterings would be found, but the spread, I think, is generally more widespread, and it is not sort of limited only to a certain set of families, etc. Certain diseases like prolonged QT syndromes tend to run within families and would tend to be familial. Other than that, but that's only a minuscule. That's a very small subset. The vast majority would be random, and it's just a matter of chance that you do have to have a child, happen to have a child with a congenital heart defect.
As far as the embryological development concerned, this embryo, right? In which trimester is the deciding factor, like a first, second, or third? Probably the third is not relevant as far as the heart development concerned. Like which part is most important as far as the child is going to have this normal heart or some sort of defective heart?
So just to rephrase that question, what I would say that the 16th to the 20th week is the most important, because by that time most of the structures would have had developed. You can interrogate the fetus with a fetal echocardiography, and in 95% of the time you're able to diagnose the correct underlying cardiac defect. What also it gives you the window is that you can decide in conjunction with your healthcare providers whether you would like to continue with the pregnancy or you would like to terminate at this stage. So there are certain defects which are very, very complex. Treatment modalities do exist, but the results are not very good, and the treatment tends to span over a long period of time. So in collaboration with the wishes of the family, the parents, the grandparents, and the healthcare providers, which are the gynecologists, the cardiac team, etc., one may want to terminate the pregnancy. Generally, most countries which allow termination would have to happen before 20 weeks. So anything between 16 to 20 weeks is an ideal time to have a fetal echocardiography done. And that will generally, like I said, 95% of the time give you a diagnosis. It also helps you to plan. So when I say helps you to plan is, What I mean is that these deliveries should happen in a center which is a quaternary or a tertiary care, where the gynecology and the anesthesia team are tuned to dealing with these kind of pregnancies. You should have a good pediatric cardiology backup, so that immediately post-delivery the child can be looked at and a diagnosis established. And if need be, a surgical team can then intervene if it is needed. Most times you would be able to delay it for some time, but at least you know the path that you're taking, and that is the safest for both the mother and the child.
Following up this, how early can we see, as far as the echo concerned, to detect these heart problems that this child is having or might be having? Embryological.
So embryologically, it would the heart starts developing much earlier than the 16th week. But like I said, it sort of develops, and to get it into a structurally defined form, a 12 to 16 weeks or a 16 to a 20 week is the ideal window. So before that, the heart is still sort of evolving and really doesn't give you a basis to decide the future on. 16 to 20 weeks, I think, is a good window to enter.
The question here is a little specific, since I already understand the embryological circulation in the fetus, right? So let's say in the embryo, the foraminal valley is open to bypass the pulmonary circulation, right? And there is a patent ductus arteriosus. So let's say the child, if this infant is going to have a patent ductus arteriosus, which is not necessarily closed duct, or patent foraminal valley, so during the fetal development, that's going to be open. So there is no way you can tell, or for sure be able to tell, that this child is going to have the patent ductus arteriosus or foraminal valley.
So I understand where you're coming from. I think the value of fetal echocardiography lies in being able to diagnose defects which are more complex.
More complex.
More complex. So for example, to give you an example, so let's say if you're looking at a Schoen's complex. So a Schoen's complex is where you have a small left-sided ventricle with some amount of fibrosis. There is an abnormality of the mitral valve. There is an abnormality of the outflow from the left ventricle into the aorta, which is the main vessel which is going to be carrying blood to the body. Now, if there is no flow into this, then the whole system doesn't develop. The beauty of fetal echocardiography is that it gives you this diagnosis, and there are modalities now where you can do an intrauterine intervention, in the sense that if you are suspecting a Schoen's complex or a very tight narrowing between the left ventricle and the aorta, there are now modalities where you can dilate the aortic valve. So this now establishes the normal flow from the left ventricle into the aorta. It allows for the growth of the ventricle and the aorta to take place. You may actually not have to intervene after the child is born. So that is where the beauty lies. The other examples are like tetralogies. So preoperatively, you can establish the diagnosis. So now you can advise the mother to have the delivery at a quaternary center. Specialized center. The mother is now actually prepared. So it doesn't, I mean, I can understand how devastating it must be for a mother to deliver a child and then to be told that he's got a congenital heart defect, which will need intervention. So the mother has already sort of been prepared for it. It comes as a less of a shock. And the whole environment is now sanitized towards taking care of the child. We can then decide as to when the intervention will happen, what will be the intervention, and it is all under control. So there are no surprise elements which are built into that.
Exactly. So that means you can pre-plan as far as these next steps concerned.
Absolutely.
Let's say if the family is not necessarily was not able to detect this in the early stages. So what are the signs or symptoms that parents should be paying attention in order to detect if there is a congenital heart defect in the infant?
Okay, so the first and foremost thing that I would like to say is that there should be a very high index of suspicion. Uh, Only if parents have a high index of suspicion would they be suspecting a cardiac. Otherwise, generally people tend to say that it's a lung problem and so on and so forth. So if you have a child who is not feeding properly, the child has a breathing rate which is very, very rapid.
Rapid breathing.
There is mottling of the skin. So when I say mottling, it's like marbled kind of a skin. The skin color is not uniform. Or you feel that the limbs are very cold. Or you find that the child is very, very irritable and you're not. So generally, if a child is kind of cranky, you console him, he should settle down. If you're not able to do that, and I think most important, if you notice discoloration, and by a discoloration I mean the lips, the nails, the tongue are on a bluish side.
Right?
Yeah, this around here on the tips of the nail. If you find that they are a little on the bluish side, don't ignore this. Blueness should never be ignored. You need to go consult a pediatric cardiologist and carry it forward from there.
Yeah, because just doing this echo is first of all safe, a lot safe, and then also easy to do and easy to obtain echocardiographic evaluation, right?
So in today's environment and in the developed world, I would say yes. But having said that, there are still a lot of areas in this world where access to an echo is a luxury. But all is not lost. What I can say that there are certain other things which one can look at and do before an echo, right? So a simple examination of the child by a qualified pediatric doctor.
Yes.
So you can feel for the pulses. If they're not equal,
And extremity pulses.
extremity pulses. If there is an inequality between the upper and the lower limb, you can start suspecting coarctation.
The auscultation.
Auscultation, the murmurs are there for you. Just general examinations, feeling the size of the liver, putting a hand on the precordium and feeling for the heart, gives you a lot of sort of leads that you can then follow. X-ray is something which is available across. It's an investigation which is not valued too much in today's gizmo-driven world, but it gives you a lot of information. So the shape of the heart, the way the vasculature goes into the lungs, the contour that the heart sort of creates, the size of the heart, the size, when you compare it to the size of the chest. Gives you a pretty good idea as to what you are sort of dealing with. Things like TGA have got a typical egg on side appearance. So if you have something like an egg lying on the side suspended by a string, you should start thinking of a TGA. If it fits in with the other findings of cyanosis and increased flow, you pretty much have a diagnosis before you even go for an echo. ECG again can help you. I absolutely agree with you that in today's day and age, and echocardiography by a good pediatric cardiologist, and I would say here, a good pediatric cardiologist, not anyone. An adult cardiologist would not be able to give you the same information that a pediatric cardiologist would, right? So I think one should drift down to a good pediatric cardiologist and get an echo done. So what the echo is going to tell you is it'll give you a whole plethora of information. It'll tell you about the structural defects. It'll tell you whether you have holes, whether you have blockages. It'll tell you the flow through the blood vessels. The gradients. It'll also tell you the functionality as to how good the pumps are doing. It'll give you a whole lot of information on how the valves are performing. Right? And you can then also help you to time the surgery.
How urgent you have to do it.
How urgently you need to do it. And I think the beauty about echocardiography is that it can be repeated. There are still no known side effects of doing an echo examination. So an echo examination can be repeated very frequently. Just to give you an example, let's say the child has a premature child. He's got a PDA. We start some medication to try and close the duct. So one can actually keep repeating the echoes and seeing whether the duct is actually closing or not. If it is not closing, then you can move to the next step.
Closure.
Whatever.
Yes.
Right. So it allows you the luxury of being able to repeat it frequently without any adverse effect for the child. So you have qualitative endpoint data, which is
With
available
follow-ups.
to you. With follow-ups. Yeah.
To sum up briefly, the first is that parent education is the key here.
Correct.
And second, they have to be aware of those signs and symptoms of what they should be looking
So
for.
most important is everything else can be ignored, but not blueness.
Exactly.
So if you have a child, for whatever reason, if you feel that the child is dusky, let me not say blue, let's say it's dusky or is looking off color, don't ignore it.
Yes.
Please go and meet your
Evaluate that.
There are a lot of simple tests to do. A pulse oximetry with oxygen will help you to differentiate, and so on and so forth. Yeah.
So let's move on. And what type of congenital heart defects in infants you see most common?
I would Dilshod, drag you back a little here.
Hey, go ahead.
Yeah. So what I would like to say that echocardiography would give you, I think, about 85-90% of the time you will be able to go ahead and take a decision on what to do and when to do. Right. Sometimes echoes still put you into a gray zone. That is where things like cardiac MRI are coming up. Amazing modality. It gives you so much more information than what an echo would be able to provide. Certain challenges that technically it is difficult to put a child into an MRI machine. Yeah.
Yes.
But if it's a center which is doing it on a regular basis, that's pretty much taken care of.
They're used to all that.
They're used to all that, right? CT angiography, because there are certain blind spots in echo, like you cannot very well look at the distal pulmonary arterial bed on an echo. The information that you get may be suboptimal. So a CT angiography in this situation would be very, very helpful to you. And obviously, if you need hemodynamic data, the gold standard still is a cardiac cath, right?
Yeah.
So what generally most people like to do is they tend to put them into watertight compartments. I think a better modality is to look at all of these as complementary.
Yeah.
So if you start off is going to be always echo. If it gives you all the information that you need, fantastic.
That's it.
If you're not, then you start building block by block.
Move on.
Yeah, move on.
Yes.
Keep getting a building block to add the information to what an echo is giving you. And then ultimately, when you run through the gamut, you are pretty much sure as to what you're dealing with.
Because I remember back in the days that you told me about this, I have to do the cath because those modalities are not able to measure the pulmonary hypertension.
Correct.
Unless I go into the heart and measure the pulmonary artery hypertension, level of the hypertension, I will be able to tell you whether we can do surgically correct this or what can we do as far as the next step concerned.
So despite a lot of water having flown under the bridge, still holds true. And unfortunately, more so for countries like Uzbekistan and India, where the children don't come up for surgery on time. So the secondary effects of congenital heart defects, and the commonest of that is having lung pressures which are very, very high. They have to be evaluated. Cardiac MRI to a great extent and along with echo can help you. But sometimes it is an angiography, which is just going to give you so much more confidence.
Structural information.
And the reactivity of the bed and the pressures. It just gives you so much more confidence when you are counseling the parents and you're sure about what the outcomes are going to be like, how challenging is going to be the ICU stay. It just adds that additional layer of confidence. And I don't think it should be looked on as the bad boy in today's environment. Where it is needed, I think cardiac catheterization has a very important role to play.
That probably means when you detect and how much this situation has been delayed also makes a lot of difference, right? Because if in the early stage, pulmonary hypertension may not necessarily be as high, but
Correct.
the parents are delayed the detection. In that case, then you're going to have to go all the way to the cardiac cath, right?
True, absolutely true. I think let's look at a VSD as an example, right? So essentially what happens in a VSD is that there is a hole between the lower two pumps. And since the pressure is more on the left side than on the right, whenever you're going to have a hole, there'll be excessive blood coming from the left to the right. Shunting. So that's known as a left to right shunt. And this will eventually have to go through the lungs. So if you're going to put an extra amount of blood into the lungs are going to tend to protect themselves, and the lung pressure goes up as a consequence of that. Right. When the child is young and you close the VSD, it can almost always be guaranteed that the vascularity will come back to normal.
100% recovery.
100% recovery, right? The structural damage is not fixed. Now, if you leave this for longer, then the longer the insult of the increased amount of blood flow, structural changes start happening within the lungs. Now, when this is the subset that you encounter and you go and close the VSD, you may actually be subjecting the child to a situation where the right heart is now not able to deal with the very high lung pressures and the right-sided heart fails. You may actually have what is known as a hypertensive crisis where the heart is just not able to pump the blood and the heart stops.
Against the
resistance and the heart stops. So before you commit yourself, you need to know as to whether the reactivity still exists. Are the lung pressures still going to normalize once you close the hole or not? So that brings us to an existential question and a very important question. When should you be operating on children with congenital heart defects? So generally, what happens is in your country and in my place, the parents will know that my child has, now they have access to echoes and all. So they will know that my child has a congenital heart defect. But then there are so many social dogmas which are going to come in.
Don't touch it.
Don't touch it. The grandparents will say, no, it's a death sentence.
It's going to heal by itself.
A lot of people say that. Then some people also say that there's no point in trying to do anything for the child. He's going to be dead in any case. Whether you do something or you don't do something, it doesn't really change the natural history. Financial constraints are important. Intervention can be a little expensive. Then what is also there is that there is a paucity of places where you can have access to high-end cardiac interventions and surgery. So most times, even when they know that they have a child with a congenital heart defect, because of regional paucities of the manpower and infrastructure, financial constraints, and social dogmas, they may not reach out to the right people to address the issues. Now, what happens is that this then complicates the issues. So some of the commoner complications of delaying is that the lung pressures can become very high, very elevated, which will then become a challenge for the post-operative period. In certain cyanotic heart diseases, you may have what is known as a coagulopathy. So this is the inability of the blood to clot. You have higher bleeding tendencies. So they can bleed into the brain and have strokes, etc. The heart muscle, since it is doing work against so much of load, excessive work, it tends to become thicker. And a thick muscle is bad for the heart. It's not like bodybuilding. If you have a thicker muscle, it's probably bad news.
It's a pathological hypertrophy.
Exactly. So it tends to impair the recovery on a long-term basis. And sometimes the damage is irreversible. The fourth challenge is that a normal heart has a prescribed rhythm, right? So because of the hypertrophy, because of the scarring, because of the lack of oxygen delivery, the normal conduction sequence is lost. So you then start having arrhythmias. So when you start having arrhythmias, generally, even if you correct the defect, you're never being able to get back to a normal sinus rhythm. So before any of these things happen, one should be intervening. So then again, it sort of comes back to the question, when should you intervene?
Yeah, tell me, when should you intervene?
So if you were to follow a rule of the thumb, most cardiac defects should be treated probably within the first 6 months and at an outer limit by 1 year of age. There's certain defects which are very minuscule, about 10 to 15%, like an ASD or a bicuspid aortic valve or some congenital valve pathologies, where you can sort of wait, or you would like to wait and intervene later. But the vast majority should have had some sort of a intervention, either surgical or a catheter-based intervention, before they reach the age of 1 year. Within this subset, there will be about 10 to 15% where this needs to happen within the first few weeks of life. And the example that I can give you is a TGA with an intact transposition. Now, what happens in a transposition is that the origin of the main vessels gets switched. So the pulmonary artery, which should be coming from the right, comes from the left, and the aorta comes from the right. Now, what that does is it doesn't allow the blood to get oxygenated in the lungs. So you have duskiness, you have blueness, etc.
So this is potentially life-threatening.
It is. And it needs to be tackled and operated within the first 2 to 3 weeks of life. Similarly, a TAPVD, where the veins, bringing blood back from the lungs, instead of draining normally into the left side of the heart, are draining towards the right or into the hepatic system, subdiaphragmatic. Again, if you are not intervening early, the child will probably not survive. And the later you intervene, the worse are the outcomes. For the same matter, critical pulmonary stenosis, critical aortic stenosis, interrupted aortic arches, all of these need intervention early. So if I were to sum it all up, what I would say is that the timing of the surgery would be decided by the underlying pathology. So what is the congenital defect that exists? That will actually determine as to when you should intervene. This intervention can happen as early as day 0, but in the vast majority of cases should be done before the child reaches 6 months, maximum 1 year. 10 to 15% you can wait and go beyond, but 90% should have had it within the first 1 year of life.
So the smaller defects, as you said, this PDA, smaller PDAs and smaller ASTs, if it's small, they can wait some time, right?
Yes. So
if there is no circulatory
So if
problems.
I am not going too technical, basically what you need to see is what are these defects doing for the heart. How do they compromise the functionality of the heart and the lungs?
Circulation, yes.
And the circulation. If that is not happening, then probably you can wait. Now, when I say you can wait, it doesn't mean that you wait 10 years or 15 years.
Leave it alone, yes.
You don't put it on the mental shelf and forget about it.
Yeah.
No. So it is there. It's a very, very conscious decision that it has to happen someday, but not today. You would still need to be in touch with your pediatric cardiologist who would be following you on a regular basis. And the intervention would depend on a time which is most opportune for that lesion for the child. So it has to be tailored for the child. It is not one size fits all.
Yeah. Right. That individual case by case basis.
Case, individual, the pathology, the timing, and the other sort of factors which are built into it.
To sum up what you just have explained is basically the elevation of the pulmonary vessels is not necessarily a primary problem. It's just a secondary because of the we delayed the treatment of the primary problem. It's gonna create another problem that we're gonna have to deal in the meantime while we plan to treat the patient, right?
Correct. So the hole in the heart per se is not going to rise or raise the lung artery pressures.
Yes.
The lung artery pressures are raised because of the excessive amount of flow and the way the lungs tend to then deal with that and protect themselves. So the longer you wait, more damage happens.
Reactive change is going to
Exactly.
go on.
It'll keep going on. Structurally, the lungs will change to try and protect themselves. And if you reach, so there is a gradation for this. If you are a grade 5 or a grade 6, Heath Edwards, then it is unlikely that you're going to benefit from surgery. You may be able to close the hole,
Yes.
but you'll not be able to reverse the effects on the lungs.
Yeah. The reversibility may not necessarily happen there,
Correct.
right?
Absolutely.
Okay.
So the correct timing and as early as possible is imperative.
Yeah. Briefly, if you could tell us the difference between pediatric cardiac surgery and adult cardiac surgery. I already got the nuances right there, but just for the viewers that they are not necessarily knowledgeable, at least as knowledgeable as you and I.
So there is no comparison.
This is a completely different
They are
world.
completely different. Child is not a small adult.
Yes.
The physiology
Exactly. That's the point.
physiology is different. The way they respond to medications is different. Their recovery potential and the capacity to recover is different.
Yeah. Body reserve is also
different.
less.
The organ systems, if you're operating on a 1 day or a 2 day children, are immature.
Yeah.
So the way they respond to cardiopulmonary bypass is going to be absolutely different. So there is no comparison. It's like trying to compare oranges to pineapples or something of that sort.
Yeah,
right?
because as you said something like key moment here, like a child is not a small adult.
It's not a small
It's
adult
a completely
at all.
different
Yes,
human
absolutely.
being. It's like you have to take care of this.
Yeah. So the
individually.
offshoot of that is that adult cardiologists and surgeons and nursing staff cannot be looking after pediatric children.
They have to be specifically trained.
Exactly. So in most good centers, it has now become a norm that the pediatric cardiac units are going to be separate from the adult units. Nothing is shared. No infrastructure, no nursing, no doctors, nothing. You probably the only thing that you share is the labs and the radiology. Other than that, everything is different, and rightly so. Because the needs and the challenges for a pediatric patient are entirely different from an adult program.
Okay, now it's like, let's say we detected the heart defect, right? So what is the approach? Like they come to the pediatrician or pediatric cardiac specialist, right? Then they refer to you, the patient. So as soon as they come to you, you take over the patient. And what are the sequence of events that happens usually?
So Dilshod, it's going to be a team effort always. And the strength of any good program depends on how good the teams are, how collaborative they are, and how well can they communicate with each other.
Communication, yes.
So the care of a child with a congenital heart defect is going to be taken care of by a cardiologist, a surgeon, a pediatric anesthetist, the scrub nurses, the intensive care nurses, the intensivist, the physiotherapist, the nutritionist, and the other ancillary staff.
They're tightly related.
So they are very tightly bound to each other. Yes. They are sometimes sequential. Sometimes they'll be running in parallel. So you can't segregate one from the other, right? So it is imperative that good teams are established. And that is where the legacies of centers come in. So centers like our center, which is like here for about 25 years, we would be able to give you absolutely different outcome than a center which is just probably 6 months to 1 year old. So it takes some time for the centers to mature, reach a level of excellence. The trust and faith and Sometimes it is
And
only
experience as well.
Absolutely, and sometimes the team works seamlessly. I mean, everybody knows what you're thinking
It's like
about.
a one body.
It's like one body. So
Yes.
different bodies, but one mind. So trying to get teams together is imperative. What you also asked me in that question was that how do you treat? So in today's environment, there are a lot of modalities that can be sort of utilized. Just to touch upon a few, the commoner ones like an ASD, which is a hole in the upper
Atrium.
between the upper two chambers. So this can be addressed either with a device or it would be addressed by surgery. Which of these two modalities you're going to use will depend basically on where the ASD is situated and what the size and the other ancillary defects which are there. So you may have an ASD with a leaking mitral valve. Device, not a device. If you have an isolated ASD which is amenable to a device, the results are as good as surgery. When it comes to surgery, you have a whole plethora of ways of closing it. You can choose the incision site. You can choose the length of the incision. You can choose to do it endoscopically. You could also, if the patient is bigger, you could also use robotic surgery to try and close the defect. All of these would have their own strong positives and negative. There is no one process which has
Fits all.
fits all.
Yeah.
And there's no one process which is supremely better than the other one.
Yes.
So, like we discussed and said in the beginning also, it has to be tailored to the patient. What are the
Case
needs?
by
of
case
case by
application.
case, yeah. And it has to be tailored for that. Again, if you look at something which is like a narrowing in the aorta, which is known as a coarctation, again, you could approach it either with a balloon dilatation or you could use surgery. There are different ways of doing surgery. So the whole plethora exists. In some settings, you would only want to give medication and stabilize the child and then take him forward from there. He may not need any other intervention other than some medication. So different modalities. Again, you got to target the patient as an you got to treat him as an individual. So you can't paint everybody with the same brush.
So after evaluation, you pick the best possible way of treatment for that individual patient.
So each team would work differently. I'll just highlight the way we work. So if the patient walks into the OPD, he'll probably either come to the surgeon or the cardiologist. Either way, the first interrogation would be with the cardiologist, who will examine the child, do the necessary basic tests like X-ray and ECG, and also conduct an echocardiographic evaluation. Subsequent to that, there will be a team meeting, which would comprise the cardiologist, surgeon, intensivist, and anesthetist. We would chart out the best plan for the child. And then you sit down with the parents and explain it to them. And depending on what their wishes are, then sometimes you might want to modify things a little.
Yeah.
But you are basically acting as a facilitator or as a guide,
Educator,
or as an educator. I think that's the better term. As an educator for the family to come to a decision as to what they feel best for the child.
Yeah.
We can only handhold and help them to make the right choices.
Exactly.
So that's the way it works at our center.
Yeah, in the past, I have participated some of your counselings for the patients in the past, and this problem, I would say, not only medical, it's a familial, also the social, and then also economical, and I would say there is an emotional part of it. So, like, as far as your practice concerned, so which part is the most I would say complex or painful, difficult for you as far as managing these concerns, since you already are very skilled in your job. So, but there you have to deal with the patient's family, all these questions, like, what happens to my child? Is he gonna be all right and stuff like that? So how you handle, how hard it is? Could you please share that?
I'd rather not, but yeah, I would say that it's
hard.
It's extremely hard.
Yeah.
It's extremely hard, and
it's harder than operating the patient.
I would say operating is the easier part. Most difficult before surgery is how to be able to communicate to the parents in a language which is non-technical.
Accessible to them.
And accessible to them.
Yes.
It is also very difficult to create an environment for them where they can ask you the questions which are there on the mind.
Yes.
Most parents hesitate. They will not put things on the table.
Scared.
So they're scared.
Emotional.
They also feel that asking a question may be something which is very stupid.
Yes.
But they have to understand that there's nothing stupid. So they need to ask.
Yes.
They are hesitant. That they're just not able to. They feel that if they ask something which is for them is important, but they feel that for the surgeon may not be important. But I would sort of encourage parents to ask questions, whatever it may be. And every question is a valid question. Every question is a very, very important question, and it needs to be addressed. Has to be addressed. So that becomes a challenge for us. The other very difficult part for us is to invariably always ask what is the success rate for the surgery.
Yeah.
That is very difficult because there's so many factors which actually go into and play, and sort of there are layers and layers within layers. These are like one of those magic dolls.
Yes.
You keep taking out the doll and another one doll comes out. So that becomes very difficult.
It's not a yes or no
It's
question.
not a yes or no. It's always a gray zone. It's always a gray zone, and that becomes challenging. Also, you are sometimes at crossroads with yourself. After all, it is somebody's child, and he's handing over something which is the most precious to them.
Yeah.
He's giving them over to you, who's an absolute stranger.
Trusting you.
Trusting you.
Yes.
How do you live up to the trust?
Yeah.
When there are so many variables. So it can be very, very emotive. It can be very traumatic for both the parents as well as the surgeon.
Doctor, yes.
And I think the most difficult one is those last 10 steps when the child is not doing well, to be able to walk up to a parent and to tell them that the kid is not doing well. Very difficult.
Yeah. Yeah. I've witnessed in the past with you some of those kids, like with the pulmonary hypertension.
Correct.
That parents are asking, like, what's going to happen?
Yep.
What happens? What happens? And stuff like that.
Yeah.
It's very hard.
So if the child is not doing well, that is very, very difficult. Yeah. But there's something which you have to deal with. It's part of the game. And unless you're able to walk that step,
you won't be able to help.
You are not able to help.
No.
So over the years, you kind of sort of relook at it from different angles. You train yourself. You take help from your peers and other people, and there are some support groups for us where you learn how to deal with this and take it and integrate it into what you do.
Yes.
The rewards are
worth it.
I would say more than worth it.
More than worth it.
You can't put a price on it.
Yes.
You can't put it into words.
Yeah.
I just don't know how to even explain it. If you have a child who's sort of dying, and when he's 2 days old and you operate on him, he does well, goes home, and then after 13 years, he comes back to you.
Yes.
It's just amazing. It's just amazing.
I haven't even participated the procedures and like the steps, but I've seen patients who you operated in the past, and I was back in the Tashkent, right? Seeing the joy in their eyes, like I wasn't here, even I wasn't here, but I've seen the joy, and I've seen the gratitude they feel. That was like something else, like you said.
It's amazing.
It's worth it.
You can't put it into words. You just have to feel it.
Yeah.
You just have to feel it, and that is what makes all the hardship, all the sweat and the tears and
like this.
blood and the pain, it's worth it. If somebody were to ask me that, would you like to go through this all over again? Absolutely.
Yeah.
There's nothing else which I would want to do. Pediatric cardiac is what it is.
You're going to choose it again.
I'll do it again, without a doubt.
Awesome. Beautiful.
Without a doubt.
Beautiful. Yeah. That's awesome.
And I think it's a blessing which has been bestowed on me, that I have this skill set. It's amazing.
Based on this today's topic and discussion, what would be your advice for the new coming doctors who actually are looking into pediatric cardiac surgery? And would you encourage them to be a surgeon like yourself?
Like I said, if I'm willing to do it all over again, I would like other people to look at it and look at a pediatric cardiac surgery especially as a challenge.
As a challenge.
So you can be either climbing small mountains, it
Yeah.
probably won't give you any satisfaction. Or you could be tackling the big peaks like the 8,000ers, like the Everest and the K2s. So the risks are there, challenges are there. There's more effort which goes into it. But the joy and the ultimate sort of satisfaction which you get,
Accomplishments.
and the accomplishments, the feeling of having done something good. And something good means in the sense that technically as well as emotively, as well as reaching out to people and bonding with them is unparalleled. I think that's the word which can come closest. As unmatched, it is unparalleled.
Yes.
So if I were to be advising the youngsters, I would say just go for it, man. Don't think about it. Just go for it. Put in the hard work. The results will pay for themselves.
Yeah, there is a saying, the higher the risks, the higher
No
the
pain, no gain.
reward. Exactly.
The no pain, no gain.
Yes, as simple as that.
So it works absolutely for pediatric cardiac. I wouldn't say pain. I would just say challenges. I think just go ahead, do it. Yeah.
Okay. To close our podcast, what's your word and your advice to parents or the possible potential parents or families?
Okay. Right. I understand the pain and the angst and the absolute turmoil which happens when a young couple are told that the child has a congenital heart defect.
Yeah.
So a moment which would be joyous and would be full of gaiety just comes crashing down and becomes one of absolute terror. And the terror comes from the fact because they do not have the relevant information.
Lack of knowledge
To be able to deal with the challenge.
Yeah.
I would not say advice. I would a suggestion would be that don't give up hope.
Yeah.
There is so much which can be done in today's world, and in the vast majority of these children will lead happy, healthy, fruitful lives like any other normal children.
Yeah.
So keep the hope. Be willing to educate yourself.
And ask
So
questions.
ask questions. Reach out to people. Reach out to multiple people. If somebody is saying no, it cannot be done, don't take that as a closure.
Yeah.
There are other people who are willing
Second
to help.
opinion.
Go for a second opinion. Go for a third opinion. So what I would say that exhaust all the opportunities which exist for you. Always be hopeful.
Exactly.
Results are phenomenal. They're very gratifying. They can be challenging, but yes, they're very, very good. So I have now so many children who I had operated 20, 25 years back. They are
Adults.
married. They've done, they educated themselves.
Yeah.
They're leading independent lives, and they have children of their own. And the children are absolutely happy, healthy children.
Beautiful.
So why give up hope?
Yeah.
So it is like a challenge. It's like a slap in the face. It can be very, very daunting, but please do go out, explore, get the knowledge, read, go to the website. There's so much of a material which is available on the internet these days. Don't treat that as the gospel truth. Just use that as the guardrails.
Educate yourself.
Guardrails, educate yourself, go and meet the right people. The sky is the limit.
Exactly.
Yeah.
Dr. Dagar, thank you very much for
You're
your
always
beautiful
welcome, Dilshod.
podcast today.
It's always welcome.
And we learned a lot from you. And I hope we're going to talk about this topic even further in the future.
I love to do that.
Thank you very much
Yeah.
for,
I'll have to do
for,
that.
for accepting our invitation.
It's always a pleasure, Dilshod.
Thank you, sir.
You're welcome.
That was good.